And now we're recording. So today's webinar is going to be 510K submission devices containing software. Almost the biggest trend I'm seeing throughout, it's really been for the last 18 months, but certainly the last 12 months, medical device companies are making everything integrated with mobile devices and software everything. So I need whatever information your device used to give you before. Not only was it digital before, but now we got to have it on our mobile device, and we got to have it in the cloud, and we got to have it communicate to our doctor and our best friend and our dog. So with that goes cybersecurity risks, software validation, much more complex architecture. And now the next wrinkle is, we used to have an algorithm before that was based on something in literature or something we had developed as a scientist. Now we're just going to have a computer develop it for us with AI technology. So artificial intelligence is changing the landscape and making it easier for companies to develop their own algorithm that's just a little bit better. And so now, instead of the focus being on writing equations or algorithms, now the focus is on trying to create the best database to train your algorithm on. And we're seeing everything's being integrated with mobile devices. And so that is a big obstacle for companies that used to, before it was, I need something that is a toothbrush. Now I need a toothbrush that's electronic. Now I need a toothbrush that tells me how many times a day I brush my teeth and communicates with Facebook. So Mary's going to talk a little bit about how that changes what you need to do for a 510K submission and what the documentation requirements are, and specifically some of the things that she's learned over the time helping companies try to prepare their 510K submissions in this new world where everything's digital, everything's mobile, and everything's communicated with every device and type of interface that we could possibly imagine. And it's a trend that's not going to stop. So I will turn things over to Mary. If you have any questions, please put them in the chat box. If you have confidential information, please hold off and email us like a non-disclosure agreement. We'll execute it, and we can schedule a call with you to discuss your more confidential issues. But for any generic questions, don't hesitate to email or chat, put it in the chat box, or you can unmute yourself and ask the question. But if you have any questions, please ask, because it's probably makes the session 2-3 times as effective when we're hearing interaction with the audience and asking the things that are on your mind, because otherwise we just have our perspective, which is quite different from people that are actually developing the devices every day. Off to you, Mary.
Thanks, Rob. So yeah, like Rob said, we've worked with a lot of different companies, everything from AI software to mobile technologies to health IT. And a big part of my job is coaching these companies through the software development process. And the FDA has issued a lot of guidance documents and recognized different consensus standards to establish the framework for quality software development and to outline the required documentation for regulatory submissions. But many software developers are not intimately familiar with these requirements and could end up with a scramble ahead of submission. So in today's webinar, we're going to go through the requirements and guidance at a high level to try and just paint a complete picture of the expectations of your company with regard to software development or software as a medical device. And I'm also going to spend a little extra time focusing on some of the newer guidance documents that were released in the last couple months and areas where we've seen companies struggle with their FDA documentation, and specifically some cybersecurity issues that are becoming important to focus on. So Rob, if we go to the next slide. The topics that we're going to cover today is the regulatory or the regulations and standards that govern the software development in medical devices, the FDA's guidance documents that they've produced to help establish the framework for these activities, the overall software development process and the documentation content for 510Ks, specific verification and validation testing requirements, off-the-shelf software documentation, and what you need to communicate and document regarding your off-the-shelf software in your 510K submissions, pre and post-market cybersecurity requirements, changes in your software and whether or not that requires a new 510K. And then we're also going to be looking at some forward-looking FDA papers about artificial intelligence and machine learning applications in medical device software. So we'll touch on that as well at the end. Next slide, please. So like Rob was touching on, the vast majority of medical devices these days seem to have some element of software, and they rely on software to function safely and effectively. And in turn, software issues account for a good chunk of all medical device recalls and medical device issues. So this is a big deal to the FDA, and it's a big deal to companies that have software in their medical devices. And it's important to follow the guidelines and good software development hygiene practices to ensure that you're not one of these software recalls, or that your software doesn't cause any issues or harm to people in the field. Next slide, please. So these are the major regulations and standards. IEC 62304 is what I would consider probably the most important standard, and that's for medical device software lifecycle processes. So this is the one that's going to describe in greater detail all of the requirements of each of the deliverables that we're going to be going through. And this is the internationally recognized standard for all software lifecycle processes. IEC 82304 is similar to 62304, but it's more specific to health software and general requirements for product safety for more health IT type software as medical device applications. And it's devices that would be subjected to IEC 82304 would also be subjected to 62304, but it's just a more specific document for those types of devices. IEC 62366 is the application of usability engineering to medical devices, which is the recognized consensus standard that's called out in 62304. And then obviously 14971 is the general application of risk management to medical devices. Some of the other specific standards is the TR 80002-1, which is for guidance on the application of the risk management standard to medical device software. And then finally, the FDA regulations, 21 CFR 820 is just the general quality system regulation, and the software development would be captured within the product development section of that standard. And then general labeling provisions, how do you implement the labeling requirements into your software device, and then the rules and treatment of electronic records and signatures in 21 CFR Part 11. Next slide, please.
One comment here, 14971, they just finished, the committee that's revising 14971 just finished their job. So they have their final version, and it's going to be released, they expect, in December for purchase. So anybody that's got 14971 2012 or 2007, those versions are going to become obsolete by December. And the draft version was released last year. So if you're interested, we actually have a webinar about, or a blog about it on our website. But you're definitely going to have to purchase a new version of your 14971 standard this December.
So these are all of the guidance documents that the FDA has released relating to software. So you have your general guidance for the content of pre-market submissions for software. And this is intended to supplement the guidance for content of pre-market submissions, and just goes into greater detail about the software deliverables that are required for your 510K. And then the next is the off-the-shelf software used in medical devices, which this is one of the standards that's been recently updated, and it goes into detail about the requirements and the information and the processes around off-the-shelf software. The next is the general principles of software validation, which is an older guidance published by the FDA. Content of pre-market submissions for management of cybersecurity in medical devices is goes over the cybersecurity documentation and information that you need to provide as part of your 510K. And then your post-market management of cybersecurity medical devices kind of covers more of your post-market surveillance plan with regard to cybersecurity. But as part of the 510K, they want to see what your plan is for managing cybersecurity. So that's when that guidance comes into play. Deciding when to submit a 510K for a software change to an existing device is a supplement to the guidance for evaluating changes for a new 510K. And then finally, that last link on there is to the Artificial Intelligence and Machine Learning and Software as a Medical Device white paper. And that is not necessarily a guidance. It is just the FDA putting their thoughts out there and wanting to get some feedback. But that kind of goes over a high level where we might be headed with regard to AI software in medical devices. Next slide. So this is the flow for the software development process, and it corresponds and operates in parallel with the design and development process. So the first requirement is for design planning. And from a software documentation standpoint, that would be the software development plan. The next is design inputs, which would be your software requirements, which is your user requirement specification and your system requirement specification. The design outputs in the context of software would be your architecture design, your design specification, and your code, your source files. So that is basically the outputs where you demonstrate how all of the requirements have been put into this functional software system. And then finally, the design verification involves the software unit tests, integration tests, system tests, and then the usability validation. And then ultimately your design transfer, which would be your software release and your software lifecycle control processes. Next slide, please. So this is the guidance for the content of pre-market submissions for software. And we're going to go through each of the deliverables that are called out in this software. Rob, if you could go to the next slide. This is a snippet from our table of contents. Volume 16 is the software section, and this corresponds to the FDA volumes in their guidance for content of 510Ks. So volume 16 relating to software, we've identified all of the required deliverables within here. And the first of that is the software overview. And basically, that's a simple document where you just identify the contents of this software document in the submission, and then just a high-level purpose of each document. And not all of these will always be applicable. Your device might not have interoperability as part of it, but this is the basis that we use to build our documentation for a 510K with regards to software. Next slide, please. So the first document that you'll want to look at is the level of concern. So this is straight out of the FDA's guidance. They have these tables with questions, and the purpose of this is to estimate the severity of injury that a device could permit or inflict. And that could be either on a patient or the operator or a bystander. And so this first table that you see is for major level of concern, which would be death or serious injury. So if you answer yes to any of these questions, then that means that your device would have a major level of concern, or that your software would be of major level of concern. And then if we go to the next slide, this is the next table within the guidance. So if you answered no to all of the above questions, then you would go on to this table where you evaluate if there would be a moderate or minor level of concern. And moderate corresponds to a minor level of injury, and minor is unlikely to cause any injury. So these are the three questions relating to moderate. And if you answer yes to any of those questions, then it would be of moderate level concern. And so when you're documenting this in the 510K, it's a document itself, and we typically include both of these tables in our document and respond as we have here in the answer column. And then at the bottom of the tables, you state your rationale for what your device software is identified with regard to level of concern. And then that would be your deliverable for that specific element of the 510K. So then if we go to the next section, your level of concern will determine the documentation that you need to include. So this is another table that's taken straight out of the FDA's guidance. So once you know what level of concern your software is, then this table tells you what documentation and what level of information you need to include in your 510K submission. So obviously for the major level of concern, it's going to be the most robust and the most information and documentation you need to submit. And then for minor level of concern, you're going to have more summaries, or documentation's not necessarily going to be required if it's at low risk. So you'll notice that the software documentation identified in the left column corresponds to each of those deliverables that we had in the table of contents. So this is where, if it's a minor level of concern, the architecture would not be applicable for your submission, so you could remove that from the table of contents. But this will serve as your guide. And then the next page is just a continuation of that same table. So just getting into more of the deliverables and the requirements there. The software development environment description is one where it's they expect to see much more detail on the development environment for a major level of concern device. And that's because they want to see that quality has been built into the system, and that they have confidence in the manufacturer that there's a culture of quality and that the software development processes are robust. So that's why that's one area specifically where they want to see more information. Next slide, please. This is the rest of that table, and verification and validation is another area where they expect to see a lot more documentation for the major level of concern devices. For both the moderate and major, you need to show that you've done your unit testing, integration testing, and system testing, but they want to see the protocols for all of those if it's of major level concern, where they want to see where you've defined your pass-fail criteria. They want to see the actual data in reports, and then a summary. Whereas for moderate, you just have to show them basically the outputs of those tests, and the only protocol they want to see is the system test. So that's kind of the main differences that you'll be looking at depending on your level of concern there. And so then we'll start getting into more of the other deliverables here. So if you could go to the next slide, Rob. So the software description is the next deliverable in the table of contents, and the guidance requires these elements in blue be included in the software description. So the first is the device features controlled by the software. So, that'll obviously depend on what your device is. So if the software controls electronics, and based on, those inputs, it changes the outputs of the device. If it's a software only medical device, then obviously it would be the entire thing. So that's one element that's really dependent on whatever your product is, but that's what they're looking for on that element. The next is the operational environment. What's going to be the environment of use for your device? Is it used in an operating room, a lab, ambulatory, whatever that may be? They want to understand what the environmental conditions will be. Your programming language and hardware platform, operating system, those are all fairly self-explanatory. And then use of off-the-shelf software, or if there's any soup used in your software, they want to see that called out at this stage as well. And we'll get into more details about what more they want to see with SOUP, but this is the first place where it will be discussed. Next slide, please. The next element and deliverable for the 510K is going to be your device hazard analysis. And they like to see this in a tabular format where you identify the hazards, the severity, which is relating to the specific harms. And if you want to call out the harms specifically, you're welcome to do that as well. But this is what they require. And then the potential cause of that hazard, the specific method of control, and then the mitigation used to limit that hazard, and then the verification activity. So the verification activity, it doesn't have to be the actual written test. You can include a link to the verification testing document or a test ID that was done. But this is what they generally want to see for hazard analysis. And it also doesn't necessarily all have to be in one table. If you want to have your hazard analysis and then link your hazard ID to your verification in a different location, then you can do that. There's multiple ways to communicate the same information. And I also want to point out here that while these are deliverables for the 510K, they're also described in IEC 62304, which is that main software standard that we were talking about. So the FDA guidance identifies what you need to include, but 62304 is really a good source for more detail and description and information about what these specific deliverables and documents should have within them. So, next slide, please. So software requirements is possibly the most crucial element within software development. A lot of other things will flow from here, and making sure that you establish a complete and detailed set of software requirements is really an important step in the process. These are the different specific types of requirements that are called out in the guidance that you want to consider when developing your requirements. Any sort of hardware specifications or requirements, if there's a particular memory requirement or energy source needed for your type of device, you'd identify that in your requirements. Interfaces, if your product is connecting to any printers, monitors, keyboards, or interfacing with other medical devices, getting information from the network or getting information from other systems, then you need to make sure you identify that. And then obviously any functional performance requirements. If your software is using an algorithm, then you need to describe in detail what are the inputs to that, what are the outputs, what is the actual processing that's taking place, is there any monitoring or alarms, any sort of diagnosis or safety requirements, and requirements like that. Additional requirements that you want to include is your programming language and any related requirements to that. If there's any specific usability engineering requirements, if there's any environmental considerations that you need to consider when developing your software, security requirements, how are you protecting patient data, those sorts of things. So making sure that you are capturing every single element of your system, anything related to installation, that's something that sometimes people just focus on the functional performance and they kind of forget about some of these other things that are required to make sure that their software works. And the FDA and 62304, they expect it to be a level of detail where everything about your software should be able to trace from this requirements document. Next slide, please. So the architecture design chart is typically the next step in the process in conjunction with the design document. But this is where you can start to map out how your software is going to work and how it's going to operate. So it should include enough information to allow for review of the organization and the software relative to the functionality and to the intended use of the device. So There's again a few different ways that you can do this, but it's up to your company to determine what the lowest level will be, what will be your software units. It doesn't necessarily have to be a specific requirement, like units can be a specific function, and then those functions grouped into items. And then as you're combining those items, you get to the subsystem and system level eventually. And this is important to define your software in this way when it comes to the verification testing and validation testing, your unit testing, and then your integration testing. And we'll get into that in a little bit. But this is an area where I feel like a lot of companies struggle not understanding the level of detail required, or exactly what all needs to be included in the mapping. And again, this is one that's left a little open-ended in the standard, and it's really up to your company to determine how much information is enough information to really tell this story. And a good architecture design chart in conjunction with your design document is really helpful for reviewers in understanding exactly how your software works. So if we could go to the next slide. Your software design specification describes how the requirements in the SRS are implemented. So whereas your SRS, your requirements describe what it will do, the SDS describes how they do that. And it breaks the software into items and components, which we identified in the architecture diagram. And so it basically just takes each of those sections and elaborates on them and adds some context and narration to what each of those functions do. And it provides information for the review of implementation plan of the software requirements. And if you have specific functions in there where they run algorithms, that's where you can get into more detail on how the algorithm was built. Are there, is there a database it's referencing, or a table, or is it AI? So this design specification is really where you're going to tell more of the story about how your software works. So this document is usually a combination of flowcharts and that can look similar to the architecture, and also just detailed description of what each of those elements are. Next slide, please. So this is an example of one of the charts that you might use in your software design specification to try to explain how your software works. And for each specific component, these bullet points are suggestions of what you may include when describing each of your items or each of your units. So what are the interfaces of that particular component within the software? What is just the general description? What is it doing? Is there any data structures or workflows or algorithms that are being done in that part of the software? What are the outputs, and where's that information going? What's that information doing? And then the performance of that component and any relevant constraints. So a lot of times you'll see the software design specification will identify each of these bullets for each of the different units. And that's a good structure to paint the whole picture and to give the full story of the software. So that's what we usually recommend for this one. Next document, or next slide. So the traceability analysis is another important document, because this is the one that demonstrates all of the requirements have been implemented in the software and that they have all been verified. So that's why you have your SRS, your software requirements, linking to your architecture or your design document, and then your system test. So in this case, I just referenced a test document and test ID. They also want to see that hazards have been, any hazards that are related to software requirements, or any software requirements that serve as mitigations to hazards. You can identify the hazard there as well. Again, it doesn't necessarily have to be in one table like this. If you link from the hazard analysis document to your SRS ID, then that's another way of ensuring that all of those mitigations flow through your requirements. So this is just one example of how you can do it. But just these are the 4 elements that the FDA specifically requests in the traceability. Next slide, please. So the next document is the software development environment description. So this is where you describe your lifecycle plan. And if you have any like coding standards, then that's great to include. That's something for major level of concern devices they really want to see is that coding standards, again, just to show that you have an environment of quality. And then describe any information on the configuration, management, and maintenance plan. So as you're making updates to the software, what's your plan for revalidating that? What's your release plan? How are you making sure that you're evaluating the changes for, potential regulatory impact, those sorts of things. So those are the details that you'll want to describe in this document. Next slide, please. This is a high-level software verification and validation diagram that Rob, I think you developed this one, but it kind of connects the dots between the design and software worlds here. So your unit testing is going to be relating to your detailed design. Your integration testing is going to be your preliminary design. And then obviously the full system test is going to be more of a validation activity. And so we'll get into this a little bit more if we could go to the next one. Here we're back at this architecture diagram. So you can use that to kind of determine what would be a unit test versus what different systems or items you need to test in integration testing. For unit testing, you need to ensure that the unit has been correctly and effectively implemented per the established acceptance criteria. And then for the integration testing, that's when you're combining different units and running operations to make sure that the units are successfully integrated into the items and that the items function as they should when they're put together. So for software integration tests, you need to have them for each item, subsystem, system level, and function that combines more than one sub-layer. So every time you see 2 things in a box or grouped together, whether that's an item, subsystem, or system, those are the levels at which you should be checking the integration. Next slide, please. So this slide gives some examples of what unit and integration testing require or what they might look like. So when you're looking at the unit verification, you're making sure that a specific risk control was implemented or that the code conforms to a specific programming requirement or procedure. Whereas for integration testing, you're checking to make sure that the combined pieces of software meet the functionality. For both types of testing, you should have records that contain pass-fail criteria and the test result. And if there's any issues or failures or anomalies within that, then you need to identify them. And then the record of the test procedure and the identification of the tester. So these are some of the deliverables that might vary based on your level of concern. So for the major level of concern, you'll need to include all of these protocols. They're going to be looking at all of the acceptance criteria. But for moderate level of concern, just your output from these activities or your report that identifies what requirements were tested and that they passed, or if there were any anomalies, you'd identify that as well. But that's the basics of the unit versus integration testing. Go to the next slide. So then you have your software system test or your software validation. So this testing is when you have your final software package put together. You've done most of your verification testing, and now you're operating on what is close to your final system. And this testing should use expressed input stimuli, so real real representative input of what the software is going to be seeing in actual use, and being tested against pass-fail criteria for that. It can be combined with integration testing. If you have multiple high-level systems that then operate together, then some of your integration testing might be part of the validation as well. But the operation of the system as a whole would be part of the validation. You can combine multiple requirements into a single test with this. You're just kind of like most validation activities, you're testing the high-level functionality and the critical essential requirements of your software are being met. Another consideration is your human factors evaluation and potential usability study. This is an important one that the FDA has been requiring a lot, getting your device in the hands of actual end users and making sure that they are able to use your device as intended. So unless your device is extremely similar to another one that's already on the market, or if this is just an update to an existing system that has already been validated in the hands of users, then you're typically going to be looking at a required usability study of some level. Typically that involves about 15 participants from each potential user group. But this is one topic that's really good to discuss during a pre-submission meeting. So, looking at if similar devices if this has been required of similar devices, and then, drafting your study protocol and presenting that to the FDA, or presenting an argument for why a study is not necessary, why you've considered all these human factors elements and you don't think it's necessary. So that's something that might vary depending on your software, but it's definitely something you need to consider when planning out your validation activities. Next slide, please. So now we're getting into some of the specific guidance documents. So this one is relating to off-the-shelf. The FDA gets more specific about what documentation is required if you use off-the-shelf software. And this is the one that was just issued not even a month ago. So they've made some changes to the previous guidance that was issued 20 years ago. But we'll get into the high-level points of this one. Rob, if you go to the next slide. So off-the-shelf software in the context of medical devices is generally available software component that's used by a medical device company for which the manufacturer cannot claim complete software lifecycle control. So for a lot of companies, this might be an operating system if you're running on Windows, or it could be, we'll get into some more specific examples here in a minute, but a lot of times software in medical devices contains some element of OTS software. So this is an important area that that the FDA is focusing on now. So the important part of understanding what you need to do if you have off-the-shelf software is understanding that it's a risk-based evaluation, and it depends on the potential harm of the device on the user, on the patient, and that determines what degree of control you need to have on your off-the-shelf software. So since the software failures are systematic in nature and can't really be evaluated based on a probability like you can sometimes do for design-related failures, that's why the focus of risk management is mainly focusing on the severity of harm. Next slide, please. Could you go to the next slide, please? So this is the off-the-shelf software decision schematic. So this is included in that guidance document. And there are different requirements for documentation based off of the level of risk. So for any off-the-shelf software, you need to provide the basic documentation. And then based on your level of risk, If it is not minor, you need to move on and do hazard mitigations and describe the risk. And if it's a major level of concern following the mitigations, then you need to provide the special documentation. So next slide, please. So this is a list of the different documents that will need to be required for your soup. And so this hazard analysis that's described here. It doesn't need to be a specific hazard analysis for off-the-shelf software. This is just your general hazard analysis, but making sure that you're identifying the specific elements within there that are related to this off-the-shelf software. And then as you get up to the major level of concern, these are going to be more specific documents and deliverables for off-the-shelf software. So let's go to the next slide. And this goes over the basic documentation requirements. So this is for any level of concern, minor, moderate, or major. This is what you need to include. And a lot of companies will have this as part of their software description, where you can detail the soup, or if you want to have your off-the-shelf software as a standalone document where you go through this, you can do that as well. But the basic elements are just a title and manufacturer of the software, what's the specific version, release date, etc. Is there any software documentation that's going to be provided to the end user? Are they going to have to install it themselves? Is this something that's incorporated within your device? Making that clear. And what does it do? How does it function in your device? Why are you using this software? How do you know it works? And how are you going to keep control of the software? So this is what you need to capture. And it's important that the FDA mentioned several times in the guidance that it's really important that you mention the specific version level or release date, because they need to see revalidation if you're changing the version level of the off-the-shelf software. Since that is something that's outside of your control, if you're adding their updates, you need to be making sure it's not causing any problems. So they want to see that version level history of your off-the-shelf software within your device. So sometimes that requires a new 510K. A lot of times it doesn't, but that's why that's an important element to include here. Next slide, please. So the next step is the hazard analysis, and this is another one that is required for all of them. And again, this can be part of your normal hazard analysis, but you need to identify the potential hazard associated with this off-the-shelf software, the estimated severity or potential harm of the hazards, and then a list of all the different causes. So the off-the-shelf software failures, malfunctions, or misuse could present a hazard to the patient, operators, or bystanders. So you need to ensure that you're implementing adequate mitigations, and they define those as design mitigations, protective measures, or warnings. And they're listed there in the priority that the FDA wants to see. So if there is a possible design mitigation, that's what you want to do first. The warning, the user, or the labeling, that's kind of not a reliable form of control or mitigation. So you really want to focus on the design mitigations if you can. And then once you've finished your hazard analysis, identifying all the hazards and mitigations, then as part of the soup documentation, you need to compare the risk of using that off-the-shelf software to the alternative of if you developed your own software. So if there would be similar level of risk or more risk in developing your own, then that's reason to use this off-the-shelf software. But the FDA wants to see that you've gone through this exercise and made that evaluation with that. And then if you have any existing data using this off-the-shelf software or any experience previously where you've used this and it's been functional, the FDA welcomes that type of information as well if you want to include any additional data or a narrative in that regard. So next slide, please. So special documentation. This is what is going to be required if your off-the-shelf software is of major level of concern. And this is basically an audit of the software developer and making sure that their design and development methodologies are of quality. And the FDA says in the guidance that if it's not possible to audit them, then they may have an issue with you using that off-the-shelf software. So if you get to the point in development where you can't do this ahead of your 510K or ahead of you implementing this off-the-shelf software, then you may want to consider alternatives or make sure that there's a really good reason for why you have to use that software. Because you can expect pushback from the FDA if you're relying on major level of concern software that is beyond your control. So that's why they ask for that. And then they also want to see documentation that the verification and validation activities performed by the manufacturer are sufficient to ensure safety and effectiveness. So those are the extra elements that you need to include. So thank you. Sorry, the chat popped up. Okay, if we could go to the next slide, please. So just to give a couple examples of the off-the-shelf software, and these are examples that are included in the guidance as well. So a corneal topographer. So the off-the-shelf software used in this is Windows, which is used to interface with the hardware, data storage, and outputs. So when looking at the hazards of this, there's ultimately no real or significant harm that can happen to the patient. So there's a small risk of misdiagnosis, but it will not cause injury. So this is considered a minor level of concern with regards to off-the-shelf software. Next slide, please. So another example is the implantable medical device programmer. So this could be like for an automatic defibrillator or something that's implanted in the body that you can access information through the skin or something similar. So the off-the-shelf software in this case is described as DOS or Windows that is used to provide the user interface to the PC that interfaces with the implant. So this isn't the actual implant. This is the outside PC that's interacting with the implant. And when evaluating the level of concern for this one, it's really going to depend on the protection that you've designed into the implant or into the programmer. So this is one of those evaluation steps that happens after hazard analysis and after mitigation. So if you do a sufficient job mitigating these risks, then you would fall under a moderate level of concern. Whereas if you have not been able to mitigate them, then you might fall under the major. So it really kind of depends, and this is an example that could go either way. Okay, so next slide. So now that we've kind of gone through the off-the-shelf software, the next element in a 510K that the FDA has some specific requests for content in the submission is with regard to cybersecurity. So there are two guidances on cybersecurity. This one is the pre-market submission, and then they have another one for post-market that we'll be getting into after. But this is required for all devices that contain software, including firmware or programmable logic, as well as a software that is a medical device. Next slide, please. So cybersecurity is the process of preventing unauthorized access, modification, misuse, or denial of use, or unauthorized use of information that is stored, accessed, or transferred from a medical device to an external recipient. The main goal is to protect device integrity and function of the device, and protection of patient information is also important too. So, obviously there have been some cybersecurity threats recently, and there's cybersecurity vulnerabilities, which could be really dangerous in the context of medical devices. And obviously, if somebody is able to to modify the software in a malicious way or access information that they're not supposed to use. It's the responsibility of the manufacturer to try to identify those threats and to mitigate to the extent possible the risk of that happening. So that's what the FDA expects to see. And there's some, if we go to the next slide, there's some specific strategies that they suggest or require you employ. So the first is to identify and protect. So the level of security controls is going to depend on your intended use and the presence and intent of electronic data interfaces, the environment, the cybersecurity vulnerabilities, and the likelihood that a vulnerability will be exploited. So in your cybersecurity document, these are the different elements that you'll want to explain for your specific device, and use this in justifying your level of cybersecurity control. Like if you have a device where there's extremely low risk of harming a patient, there's unimportant data that might be there, or whatever minimal risk might exist, then you might be able to justify a lesser approach to cybersecurity. Whereas if you're dealing with a robotic surgical system that the operator is 1,000 miles away and it's operating over the internet, and somebody could potentially hack in and ruin that procedure, that process, then obviously that would be something that would be very high risk, high potential for harm, and you need to do everything possible to mitigate those risks. So identifying what those risks may be for your device and then implementing the appropriate protections. So if we could go to the next slide, please. So these are some of the different security functions that you can implement. These are the ones that are suggested in the guidance. And the first of which is limiting access to trusted users, layering privileges based on user role, having appropriate authentication, strengthened password protection, making sure that a session is automatically terminated after a certain period of inactivity, limit access to tampering. If you have a physical component to your device, making sure that it has locks and covers on communication ports, those sorts of things. And just ensuring that the content is trusted, and restricting updates and using encryption when storing, transmitting data. So you can strengthen your password protection by avoiding hard-coded passwords or common words, and just limit public access to passwords. Don't have a password on a sticky note on the device or whatever that may be. And hard-coded passwords are less than ideal. So if you can avoid that, they recommend it. Next slide, please. So detect, respond, and recover are the elements of cybersecurity that are when security is compromised, so that you can detect whether or not there has been a threat exercised, and you can be aware that that has happened so that you can respond. So you need to develop and provide information to the end user concerning the appropriate actions that they need to take if they have detected a cybersecurity event, and implement features that protect critical functionality even when the device's cybersecurity has been compromised. So if there's different ways that you can silo information and protect it from one another in the event of a hack or a threat, then those are some of the design controls that you can implement to protect from cybersecurity threats. And then providing the methods for retention and recovery of the device configuration by an authenticated privileged user. So these are what the FDA suggests you do. You may elect to provide an alternate method or approach as long as you have an appropriate justification. So like I said earlier, based on your device and the risk of the device, you may be able to justify a different approach here, but it's something that would need to be described. Next slide, please. So as far as the documentation required relating to cybersecurity in your 510K submission, These are the specific elements that they require, and then there's more on the next slide. But to start, they want to see cybersecurity risks identified in the hazard analysis. They want to make sure that there's those controls and mitigations for the risks, and that there's a justification for those controls. A summary plan for providing the validated software updates and patches needed throughout the lifecycle of the device, and any controls that are needed so that the software can maintain integrity during transport or communication from one point to another. And then finally, if there's any cybersecurity controls in the instructions for use, they want you to identify that as well. Next slide. So these are some cybersecurity updates for cleared devices. If your device is already cleared, you are allowed to make cybersecurity updates that don't specifically require a 510K. That's one of the specific questions that we'll see when we get into the evaluating changes. But companies with devices that have already been cleared do not need to submit a new 510K specifically for cybersecurity updates. If you're submitting a special 510K, then, or a catch-up 510K, then you should include those updates. But if it's only for cybersecurity, you don't require resubmission. Next slide, please. So with regard to post-management or post-market management of cybersecurity, you're going to see a lot of some of the same techniques recommended. If we could go to the next slide. So these are obviously going to be items that apply to devices that have already been cleared or marketed. So they want to see a cybersecurity program, a documented process that shows that you're monitoring cybersecurity information, you're maintaining robust software lifecycle process, you're establishing and communicating vulnerabilities, and handling them appropriately. Next slide, please. So different sources of cybersecurity info is independent security researchers. You might discover vulnerabilities during your own in-house testing. A healthcare facility might discover some issue. If you have off-the-shelf software, they might have discovered a vulnerability and make you aware of that. And then information sharing and analysis organizations, or ISAO, are organizations that manufacturers and government entities and nonprofits can all participate in these organizations, where you're just sharing information about security threats, potential threats, and just companies working together to try to improve everybody's cybersecurity. So that's highly recommended by the FDA that you participate in one of those. And you have some special privileges and permissions if you do have active participation in those. So that's worth looking into if you have a device that is going to require robust cybersecurity. Next slide, please. Next slide, please. Thanks. So again, with cybersecurity risk management, they want you to define and document the process for identifying cybersecurity risks, and have methods that use to identify, characterize, and assess vulnerabilities. They want to see that you have implemented methods to analyze, detect, and assess those threats, and incorporate elements consistent with the NIST framework for improving cybersecurity. So again, this is something that you would have done during the development process and in the pre-market side of things, but they want to see that you have a plan for continuing to exercise these activities post-market. Next slide. As far as cybersecurity updates go, they want to make sure that you maintain safety and essential performance. So that needs to be part of your comprehensive risk management, and define the resulting severity of patient harm if compromised. Protecting the safety and essential performance should be the top priority when it comes to cybersecurity. Patient health information and private data is also important to protect, but from a prioritization, the safety and essential performance comes first. Next slide, please. So threat modeling is basically an exercise where you look at it from a hypothetical attacker perspective and identify their potential objectives and vulnerabilities they might try to exploit. And then you define countermeasures to prevent or mitigate those threats. So this is just, again, one part of your post-market plan for cybersecurity. Next slide, please. And then the FDA requires you to remediate and potentially report cybersecurity vulnerabilities. These are some examples of how you need to be remediating them and documenting these. If we go to the next slide, this is the flow chart for when you need to, when you maybe need to report these vulnerability exploitations to the FDA. So if there was no risk of harm to the patient, then you just need to update and fix the cybersecurity vulnerability. If there is harm to the patient and it's uncontrolled, then you need to determine if the risk meets those criteria. So if you do participate in ISAO, have a remediation within the required timeline, and there's not a significant adverse event, you don't need to report it. But if it doesn't meet those criteria, then you need to report it to the FDA for 21 CFR 806. Next slide, please. Okay, so sorry, I'm starting to run a little behind already, but this is one of the last sections here. So deciding when to submit a 510K for a software change. Next slide. This is the flow chart that they have in the guidance that tells you when you need to submit a 510K. And so then this text on the right here is what we have put in our letter to file template. It corresponds directly with the flow chart. But basically, when you make a software change, this should be part of your change control process or part of your prior to release. You should go through this exercise and document this as a letter to file. Whether or not you need to submit a new 510K or just revalidate the software. But these are the, so for example, the first one, if it's only for cybersecurity, then you just need to document it. If it's not only related to cybersecurity, then you need to go through the rest and determine if it is a change that would require a new 510K. So this is straight out of their guidance document, but this would go along with your letter to file process for design changes as well. This is just the software element of that. Next slide, please. So on the topic of changes and whether or not a new 510K is needed, it raises an interesting question when you're dealing with artificial intelligence or machine learning software and devices. So there are some AI softwares that are continuously changing or have adaptive learning. So it changes its behavior using a defined learning process compared to a locked machine learning application where it applies a fixed function and gives the same result every time. So next slide, please. Everything in this section is just open for discussion right now with the FDA. But these are the different significance of information provided to the healthcare decision compared against the critical, serious, or non-serious impact or potential harm of that software. So this will kind of determine what the FDA expects for your controls and documentation if your software contains AI moving forward. But this isn't in effect yet. This is just kind of where they might be headed. To date, the FDA has cleared several devices with AI or machine learning, but the vast majority of them have been algorithms that are locked. So they're not changing in the field yet. That's coming, obviously, but right now there's still a struggle with the FDA and catching up with the technology when it comes to AI and machine learning. Next slide, please. This is their proposed software pre-certification program. And basically, the intent of this is that the FDA will assess the culture of quality and organizational excellence of a particular company, and that will provide them reasonable assurance that there will be high quality of software development, testing, and performance monitoring of products. So this is going to be one part of the qualification for companies that are wanting to implement machine learning or AI continuous software. Next slide, please. So the SPS and APC are going to be the two main elements that you'll need to include, or that you potentially might need to include in a 510K moving forward. And this basically just outlines the SPS is what could be changing or what will be changing as your software learns. And then the change protocol is the specific method that you have in place to achieve control of the risks anticipated with those modifications. So those are kind of the two elements that are going to be important moving forward if you're looking to develop software with AI. Next slide, please. So then when it comes to the AI and evaluating whether or not those changes are going to require a new 510K, this is their proposed flow chart. So if you have an approved SPS and ACP, then it's not going to be as rigorous. You're going to be leaning on documentation more. But if there are modifications relating to the intended use, that's still going to require pre-market review potentially. So that's just kind of some of the high-level things to think about if you have AI in your software or you're thinking of going in that direction. These are some of the things you might anticipate coming your way here shortly. Next slide, please. So with that kind of wraps up the presentation. I noticed there was quite a few comments and questions in the chat box. Rob, do you want to facilitate the Q&A, or do you want me to just?
Yep, I have pulled up the chat box here, and we have quite a few questions, as you said. The first question, I believe, was kind of answered by one of the audience. The question was, it seems to be the same for moderate and major level of concerns for documentation. Sorry, except for the software development environment and revision level history. And there was a table that was presented in there, but in the guidance it says which things are required for minor, which things are required for moderate, which things are required for major. And there are some differences. They aren't tremendous, but maybe you want to comment on that a little bit more.
Sure. So yeah, that slide or that table was kind of broken up into a few different slides, but mainly it's going to be relating to the level of detail provided in the verification and validation. They want to see more of that that process. So that's probably the main difference that I would highlight with those.
I remember one of the examples was if you're doing unit testing, I believe for the moderate, they're looking for a summary of what unit testing you did. And then for the major level of risk, they're looking for much more detailed details on what unit testing was done and what the results were. Is that correct, Mary?
Yes.
Okay. The next question was, how do you conduct human factors evaluation? And I think that's probably too big of a question to cover in this Q&A session. And we just recorded and released a human factors evaluation webinar that is free and downloadable from our website. So if you look on the website, you can find that. But then the next question I thought was very relevant. Is it still required for special 510K to an existing device? And first of all, for those people that don't know what a special 510K is, you can only submit a special 510K if you already have a 510K for a device and you're making a minor modification to that device. If it's a major modification to the device, then you can't do a special, you have to do a traditional or abbreviated. And the real attractive feature of being able to do a special is it's a 30-day review time clock with the FDA instead of 90 days. But when you are talking about a minor modification, it could affect the usability of the device, and human factors testing might be something the FDA wants to see, or it might be something that has no impact on human factors and usability, and therefore the FDA wouldn't need to see that. So it depends on the specific change you're making that's the minor modification. And if I were going to do it, number one, I would be filling out my letter to file decision. Is this something that requires a 510K or not? Go through the decision tree. And number two, I would be seriously considering doing a pre-sub with the FDA to see if the FDA feels that it's something that needs a 510K. We've actually had a client that said, the FDA wrote us back a letter that they processed our 510K and they gave us a 510K, but they said it could have been a letter to file and to please do a pre-sub next time prior to submitting a 510K, just in case we don't need to submit one. And the next question I would probably ask the FDA in that kind of a setting is, here's our testing plan. Does the FDA, we've provided a rationale for why we don't think human factors testing is required. Does the FDA agree with our rationale? And they can't review any data, but if you've described your change well enough and explained your rationale for why you don't think it's required, they may outright agree in writing that, yeah, we don't think you need to do any human factors testing for that. And you might even get the surprise of, we also don't think it needs a 510K, we think it's a letter to file. So doing that is, going through those steps is really important, and using the special 510K process, the pre-sub process in prior to doing a special 510K is very valuable. But if you need any help with that, that's of course what we do. And Mary's actually the one that developed the letter to file checklist that follows the decision trees that we use. The next question, did you want to add anything to that, Mary?
No, I think you captured it.
The next one is definitely all you, Mary.
Okay.
So the FDA seems to use OTS for off the shelf instead of SOUP. And if not, what's the difference between OTS and SOUP? And there's definitely a difference, but I'll let you cover it.
Sure. Yeah. So typically when the FDA references OTS, they're talking about commercial off-the-shelf software. So that would be like Windows or Git, or some of these applications that are commercial that you can purchase that you might use with your software. Whereas SOUP is software of unknown provenance, and it looks like somebody else also put in a good comment there that SOUP is open source or configurable to some degree, so it gives more control to the manufacturer. And that's right, and that's a good point, because typically you can sometimes do more verification and validation when you have that open source code, but also you typically have less information about where that code has actually come from, or what any sort of development activities that were done to build quality into that software. So those are kind of the main differences. But as far as the documentation and deliverables for the FDA, if you do have, it basically with commercial off-the-shelf software, you should be able to provide pretty much everything that the FDA has requested. For SOUP, it might be unlikely that it has the same information. So it really kind of is going to depend on the situation in the application, but those are the two main differences.
One of the comments here says, good luck auditing Google or Microsoft. That is true, that they're not going to let you come in and audit their software development process, even if you're using their software. However, you do have the ability to sign up for updates for any known cybersecurity issues and bugs that need patches. And so you can be notified that as a developer that's using their software, and monitor what kinds of fixes and problems there might be with the software that you're using of theirs. So that's something you're expected to do as part of your post-market cybersecurity plan. Um, I don't know if you
Right.
have any other ways that you can think of, Mary, that you would handle the scenario where, let's say, you're building it all on Google Suite, or you're building it all on Microsoft Windows.
So I think this is where a risk-based approach is going to be important as well. And I've not really seen too much FDA feedback when it comes to a company using Windows, that sort of thing. It's not really, I mean, it's obviously very important to go through the necessary steps in identifying if there are any potential issues with that. But it's not an automatic rejection if you can't audit your main supplier. If there are other means, like Rob mentioned, that you can be reasonably confident in the quality and security of that development of that software, then that's one part of the justification that you'll make. And that's it's not an automatic rejection if you can't audit them. But if you're using a different or a lesser known or a more interesting application, then and it's critical and there's a high risk of harm, that's where you're going to expect the pushback. So that's kind of what I've gathered. That's kind of my take. But yeah, I agree with you. Good luck if you need to audit them.
There was another comment here that I think it's not specific to software, but it is important for just our webinars in general. Can we get the slides at the end so we don't have to be busy making notes? We always make the recordings available to people that have signed up for these, and we always make the native slide deck available to people as well. And part of the reason for that is, yes, even though it's our content and we've developed it, at the same time, we also know that some companies want to use this internally for their own training, and they may want to customize the slide deck and add references to their own procedures. So we don't expect other consulting firms to use our slide deck and pawn it off as their own. But at the same time, we do expect, if you're going to use this internally for training, that there's a certain value in you giving the presentation yourself, using our slides, and adding content to it that references your own procedures and work instructions and little nuances. This is one way you could do it. This is another way you could do it. But this is how we do it here. And this is our procedure. And so you're welcome to do that internally if you're going to develop your own training program and have to train a whole design team on how to do this. The idea of the other comment I would like to make on this is when you are training and you're watching a lecture, you actually will retain more information if you are taking notes than if you're not taking notes. And because we give you the recording, you can watch it as many times as you want and continue to take the notes. Back in college, one of the things I did that nobody in their right mind would do, but I loved chemistry. So for freshman chemistry, both semesters, I attended all 3 lectures that were offered on freshman chemistry because I wanted to really learn the topic and I really loved chemistry. And so the first time around, I would take notes. The second time around, I would go back and I would edit my notes and add in the details that I'd missed or things were slightly different. And the third time, I tried to stay awake. But because I got 130 out of 100 on every single exam and get the highest grade that had ever been obtained in the school, in the history of the school for freshman chemistry, it works. So repetition, repetition, repetition. And I consider myself a slow learner. That's how I learn, is repetition. So watch these multiple times, take notes. We don't expect you to retain everything first time through. That's why we record it. And that's why you should take notes, because as one of my professors said, all knowledge goes up through pencil, into wrist, through elbow, through shoulder, and into brain. And I haven't yet figured out any other way to get it there. But my father says a hammer on your thumb will work too. The next question, We typically use Bugzilla or Jira to track and monitor
Mhm.
software issues or bugs, but this is not the same as unresolved anomalies to be submitted to the FDA. Do we have to maintain a separate list of anomalies for a 510K submission? What's the definition of anomaly? Good question for Mary.
Yeah, so sorry, this isn't something that I spent a lot of time on. I think I just mentioned it in the table of contents, but yeah, so your situation is extremely common, and it's really up to you to meet that definition of anomaly and determine which of the bugs would be considered an anomaly. And let me, Rob, I don't know, let me see. It would maybe be helpful if I shared that template real quick. Um, or maybe this is something we could follow up on specifically. If you want to schedule some time to meet with me, I can share that with you.
So Mary in her emails provides her Calendly link. And did you provide it in the last slide or no?
Um, yeah, the very final slide. So there's one more slide after this.
Okay, so I'll just advance the slide there so you can see that.
Yeah, so if you schedule a meeting with me there to discuss anything in
So the schedule a meeting link, here it is. It's https://calendly.com/Mary Votter. And that's how you can schedule a meeting with her. It just automatically links to her calendar and allows you to schedule a meeting with her. And she can even do a Zoom session like this. Normally, what I ask is I give clients a half an hour free consultation, and then if they're going to go beyond the half an hour, I say, well, we're going to charge you by the hour. You can make it as short as you want or as long as you want, but we'll charge you by the hour for that. Um, I don't micromanage Mary's time, so if she wants to be more generous, that's fine. So you can see how much you can get out of her for your session. But we love training, and we really embrace this stuff. So she probably will be generous. But on this particular issue, there's nothing that Mary said that was incorrect. However, I have seen some companies take 100% of their bugs and that they are tracking in Bugzilla and Jira, and categorize those in different levels of bugs. And so, because you're going to track them anyway, why only show the FDA some of them? Why not show them all of them? But do it in a way that says, these 40 bugs are things that are cosmetic only or have no impact. And here's the reason why we're accepting release of the product with these bugs. These other ones are more significant, but we're also releasing it with the product. These bugs here, we're not releasing our product with it until they're resolved. And I've seen this at companies I actually was the quality manager at. We had a multi-parameter monitor company, CastMed, that I worked at. And that's how we did it. We had 100% of the bugs. We tracked them in a tool that was similar to Bugzilla and Jira. And we didn't conceal any of that from the FDA because they can get it all anyway when they come for an inspection. So it's the more important thing was how are you tracking it? And what is your method of determining whether this is something that's acceptable to release or not to release? Because they expect there to be bugs. And so I find a lot of companies say, we have no bugs. And that tells me you haven't tested it hard enough yet. Or it's firmware that only does 3 things. That's the other possibility. So in firmware, yeah, I could see how you have no bugs because it's so simple. But something that's working with an operating system like Google with a browser, no, it's not going to happen ever. No matter how many times you revise that software, it will not be bug free ever. And that's just a fact of software development. The next question that was on there was, what do you mean by catch up 510K versus letter to file? So there are 2 guidance documents that Mary covered. Both of them are modifications to medical devices. One is for all types of modifications. One is for just software modifications. But every time you make a modification in your design change control process, for us, that's SYS 006, when you make that design change, you have to determine the regulatory impact of that change and whether you need to do a new regulatory filing to the US FDA and any other countries where you market that product. There's a guidance document for Europe, a guidance document for Canada, and a guidance document for the FDA. We actually have two for the FDA. When you go through those guidance documents, you determine whether it is a letter to file, and what we mean by file is your design history file, as something that doesn't require a 510K. It could also go in your DMR as revision history, but you're in your medical device file that you're required to keep for 1345 and the FDA's QSR. You're going to document whether you had to submit a regulatory submission or not, and that's what the letter to file is. If the decision is that you have to submit a 510K, then you're going to submit usually a special 510K, or if it's a major modification, a traditional 510K. Now, over time, particularly with software products, you make lots of bug fixes. Every single one of those bug fixes does not mean you have to do a 510K. Usually the answer will be letter to file. But after you've fixed a lot of bugs and you've adjusted to new operating system releases that whatever your operating system is working on requires, and maybe even added a little feature and maybe made a little tweak to the user interface or maybe changed the color, every single one of those changes is cumulative. And over time, the combined risk of all those changes is fairly significant. So the FDA would like you to do a catch-up 510K, and they use the word catch-up. You won't find it anywhere in the regulation as a type of 510K, but that is what the FDA calls it, is a catch-up 510K. And it's basically saying we've made the following design revisions over time, and each one was documented under a letter to file, and we're submitting this catch-up 510K to get the FDA's documentation current with what we currently have on the market. That doesn't mean that you have to get the FDA's approval prior to release, because you've already released it. You're just trying to get your documentation of your 510K current with what's in the field. And so one of the best policies I've seen out there for companies is about 6 months before you're expecting the FDA inspector to come back for their routine 2-year inspection, submit a catch-up 510K. And if you're a larger company where the cost of having a 483 or a warning letter is more significant than the cost of submitting a 510K, it's a really good policy. If you're a startup company that is just trying to make positive cash flow, maybe that's a little bit too conservative, and you could wait a little bit longer. But you have to make your own decision on when the risk of all the changes you've made over time is significant enough that you need to do a catch-up 510K. But I find very frequently the FDA inspectors feel that you waited too long. And just as a point of reference, I had one client that waited 40 years. That got them a warning letter and almost got them pulled off the market. So don't wait that long. We have another client that has 2 warning letters, and now they've been asked to recall product. And it's only been a couple of years. Well, I want to be more specific, I think 2014. So 5 years now. So 5 years with little changes here, little change there can really add up very quickly. And so you can get yourself not only a 483 and an FDA inspection, but a warning letter. And if you continue to make those little changes without doing the 510K, they will make you pull your product off the market. So don't do that, and be a little bit more conservative if you can at all to do those catch-up 510Ks somewhat routinely. And that will keep you current with the FDA's policies and procedures, and makes it easier when you want to make a significant modification to get that clearance in a timely manner. Do you have anything to add to that, Mary? Hello? Did I lose Mary?
Sorry, I was on mute.
No problem. Do you have anything to add?
Yeah, there's a follow-up question. If a catch-up 510K would be a special 510K or a traditional 510K?
Yep.
And I think the answer there is that it depends on the changes and on whether or not you meet the definition of a special.
Yeah, exactly. And the only hard, fast rule that I've heard the FDA say many times, because they had a new pilot where they were trying to increase the number of special 510Ks they get. They said, if there's clinical data, it's going to be a traditional, period. So any clinical data, they can't review it in the special format. There's just not enough time. But other modifications, they've really been trying to increase the number of specials that they review and to allow more things to go through that. But if it's a catch-up 510K and your product's already on the market, um, I would encourage you to take the traditional route. And here's my rationale. Um, it doesn't cost any difference one way or another. You're not on any timeline that's urgent here because you already have the product on the market. You're just trying to get the FDA's documentation current. And therefore, 30-day versus 90 days, what do you care? You're already on the market. Otherwise, it's not a catch-up. But the special 510K route, if the FDA disagrees that it can be a special 510K and they convert you over to a traditional 510K, you have to, number one, write all the summaries for the special, and then you have to revise your submission and resubmit as a traditional with full test reports. And that's just more work for you. So I would never do a catch up as a special. You can, but I wouldn't. It's just, there's no point in it. If it's a catch up, then you already are on the market. And by definition, I would just go ahead and give them the traditional because it's less work for you to give them the full report than it is to give them summaries of everything. But that's your decision. The next question was, how long does it usually take to get a response if you write to the FDA determining whether to file a 510K or a letter to file? The only way I know you could get that kind of response would be if you did a special 510K. I'm sorry, not a special, a pre-sub meeting with the FDA. If you do a pre-sub meeting with the FDA to ask that question, the process, they have a guidance document for pre-subs. When you submit it from the day that they receive it, they have 60 days to 75. That's their target, 60 to 75 days from the date of receipt to schedule a pre-sub meeting with you or give you an email response to your questions. So if that's your only question, here's our rationale for 510K versus letter to file. From the day you submit it, they have 60 to 75 days to schedule a meeting or respond by email. And which method they respond by is your choice in your request. But that should answer in terms of timeline. That's how long it takes. We typically request the 60th day, the 61st day, and the 62nd day, and we get our what we want less than half the time, but they're usually pretty close. Usually, it's the day of the week and the time of day that they change. Anything you want to add to that, Mary?
No, I think you covered it.
Okay. Next question. What is the hourly rate if we want to file a 510K? Just ballpark range. Well, if you visit our website, we actually have flat fee pricing and we have a standard pricing sheet. So it's $14,000 for a 510K. And we don't charge any different if you do a pre-sub versus don't do a pre-sub. And the reason being that if you don't do a pre-sub, we're going to probably have a lot of questions we have to answer on the back end with AI requests and RTAs. If you do a pre-sub ahead of time, usually it's a better quality submission with more exactly what the FDA is looking for. So we either put the work in on the front end or the back end, but it's probably going to take you about the same amount of time, which is why we recommend always doing a pre-sub. And we charge a flat fee. So the only thing that could drive up the cost is if you insist upon changing the scope or changing your device multiple times in the middle of the submission, then we'll switch to an hourly rate. Mary's hourly rate's $250 and mine's $300, also in that document. But we are very, very busy with submissions, but we crank them out very, very quickly. I think we had 4 go out last week. So
Yep.
we've been very busy and we do them very quickly. Next question was, is catch-up 510K or the special 510K or traditional? I think that was the follow-on question that Mary was asking about. I think that's the end of those questions. And I didn't see any email questions coming through. Does anybody else have questions? You can unmute yourself if you wish. Sounds like we have crickets. Okay, so I don't see any other questions that are in here. Mary provided the link there. We will be getting back to everybody with a link to download the presentation as an MP4 file. We're going to give everybody the native slide deck, and I will make sure in my email, my Calendly link is in there, and I will try to remember to put Mary's in there, but it is in the slide deck as well. And I'll copy Mary on it. So if you have any issues, if you see a mistake in our slide deck, let us know. We're actually in the process of we just started a project for AMI to create a 510K training course for them with Denovo. So any suggestions for, hey, this would really be helpful in a 510K course would be greatly appreciated. We've already got our own in-house course that we've created, but this is one we're doing for AMI, and we're actually looking forward to in the future potentially teaching it as well. So I don't have to deal with scheduling event venues and recruiting people to show up. Let AMI do all the work, and we get to do the part we like most, which is creating the material and teaching it. So thank you very much, everybody. I really appreciate you attending, and really appreciate the Q&A. You asked some great questions, and please don't hesitate to ask us additional questions privately. Have a great day, and thank you, Mary. If you want to stay on, we can do a quick recording after I boot everybody off for something to put on the webpage, if you have time still.
Okay, sounds good. Okay. Thanks, everybody.
So I'm going to stop recording.